All you have to do is to fix the occlusion, then maintain the result of the facial improvement. And look at the change of upper lip thickness. You rotate the mandible backward and outward, and then the upper lip thickness improves a lot. 6 months, I use lower taste to help to visualize the entire dentition. And also at the same time, you will notice that I use the intrusive labrum in the lower end teeth. Okay? Because I thought that would be a good idea that I try to hide the lower end teeth as good as possible. I don't want them to be so interactive patients. But anyway, you can see at the 9 months, actually I removed the lower intrusive labrum. And now I change the upper. I put the test between canine and first premolar. I open a little bit space before I put them in. So then I can put the screw in a safer way. And then I put screw, and then I use a pair of upper actually spring to actually upper and teeth and the positive teeth at the same time. So then the total arch actually of the upper dentition. I want to increase the upper incisors and at the same time also can help maintain the result of repositioning of the man. Of course, you have to apply intervention elastics. So I watched her for a couple months. So at 28 months of the treatment, I stopped actually in the upper dentition. I removed the biorazor as well. So when you remove the biorazor, remove the actually spring, then I would prefer to still keep the intermetal elastic to hold the teeth because I do a lot of extrusion. I want to hold the teeth and observe for the stability. Only if you are seeing the stability is good, the chin is not coming back at least for 3 to 4 months or even longer time, then you're ready to finish the patient. So don't just see the improvement of their face and bite and you finish the patients. No, you want to wait at least 4 to 5 months before you debunk the patient. So overall, I watched her for another 5 months before I debunk the braces. So you can see that now the bite from class 3, very class 3, now improving into class 1 occlusion. And also comparison before and after. You can see the upper and lower entities angulation, also intonation, the change and improvement of her face and facial profile. So the lip posture improved, the smile of the upper incisors shown improved, and also the facial symmetry improved. You may wonder what did I do for improved the chin deviation? Because actually still realize that the right side should have TM clicking. So actually her facial symmetry was not because of the different lengths of the railings, it's because of the displacement of the contact. So when I'm using the biorazor to reposition the mandible, at the same time, actually I also reposition the condyle position as well. So once the condyle reposition back to where that should be, the chin deviation improves. And that was the reason why her dental midline also improved as well. So the best policy now to improve dental midline, first you have to check whether there's a condyle displacement. If you can improve the condyle displacement, you don't have to put screw on symmetrically and you do your rotation to push to the outside. No, you don't have to. The only thing you put on biorazor to improve the ending position and condyle. Then once the chin back, the teeth goes back. Again, bone driven instead of occlusion driven. So superimposed before and after, you can see the Pogonian and the chin went back forward to 5 to 7 millimeters. Look at the change of the upper incisor position. Look at the change of the Pogonian. Looks like she had a surgery, jawbone surgery. How could I do this? Very simple, bone driven instead of occlusion driven. Okay, why did I have that? For the maxilla, actually for 4 to 6 millimeters of the total arch, the maxilla total arch. And in the mandible, you can see there were intrusion of lower entities for 2 millimeters. person want to have that. And also the lower portion teeth have 1 to 2 millimeter of extrusion. Because the upper extrusion and lower posterior extrusion, the mandible can be positioned into crosswise jawbone ridges. So overall, look at the soft tissue. Yes. The soft tissue chin also repositioned 6 millimeter and downward around 5 millimeter. So I'm wondering where are the exact increase of the total facial height. So when I superimpose that, you can see the eye to lip height. Okay, that is the distance from the eye to the lip. You can see actually after the treatment, the eye to lip height increase. So you can see the total facial height increase. Did the chin height increase in this case? And as you can see, the chin height actually remains quite similar. Although there's a little bit of increase, a little bit, that doesn't mean anything. So basically for me, the chin height remains similar. So the reason of increase of total facial height is because increase of this part, the middle part, instead of the chin height in this patient. And that is to put the eyes at the same level to get the change of the eye to lip height. You can see, yes, the eye to lip height increase. In classic patient, if you increase the middle face and decrease the chin height, the ratio was better. So for this patient, overall is another question would be why the lip height increase and chin height remain. Well, why is that? I believe that was due to the extrusion upper anterior dentition and intrusion of lower anterior dentition. So you may wonder, really, when we extrude the upper dentition, we are able to increase the lip, the eye to lip height. And when we are changing the lower incisor, are we able to change the chin height? This is a big question. So within the scope of the lip incumbence, because when we are rotating the mandible, we also increase the facial height. So lip incumbence could be an issue. So within the scope of lip incumbence, to increase the total facial height, chin height, eye to lip height, to make a lower both square facial height, because we are making the face slightly. The ratio of the face was much better, especially when you increase the middle facial height. The low angle square face. Well, I would prefer to upper extrusion and lower extrusion as good as possible. So for classic low angle square face patient, actual upper and lower dentition as good as possible. You think when I extrude too much, don't worry about that. The low angle patient, to be honest, is not that easy to extrude upper and lower dentition both. Not that easy. You go back and try, you will know, because the muscle force, the muscle carrying muscle is quite strong in lower inclination. So for those patients, do as good as you can, so that you can change their face. Once you change their face, the occlusion is not an issue. So how about a patient have average to high angle patient? Why do the same to actually upper low dentition as good as I can? Especially in this patient, in an average to mild high angle patient. Look at her chin height. I think her chin height now is good or even a little bit more for Asian female patients. So in this patient, if I increase the lower total facial height, especially the chin height, could be the issue in this patient, since the patient might still would having a crafty chin. Why is that? Because this length, this height. If the chin height is pretty low, although you put the chin back, the patient could still look crafty, especially when they smile. So CT scan showed yes, she was an average to mild high level crafty rather than a mental hypoplastic. There's no obvious facial symmetry. So intraorally you see crafty upper and lower, mild to moderate anterocrowding. Okay, in terms of occlusion driven, are you able to fix the bite? without surgery? I think so. But again, you have to have home treatment thinking process. So for me again, non-injection. Right at the beginning, I put on the vibrator to decrease the chin projection and using bilateral vertical elastic to do upper and lower extrusion. So 1 month you can see immediately facial profile improvement and decrease of the chin projection because of vibrator. The purpose of vibrator is to decrease the chin projection. Okay, 2 months. I put a lower taste to help to visualize low dentition to improve the overtone. Because when I rotate the manual back, I still have a little bit cartridge, so I want to use the taste to move the dentition, lower dentition back a lot. Some. Do I have to move a lot? No, because I put the chin back already. For 6 months after test, I do thoracic extrusion to extrude the upper dentition. I still keep using the biorazor. 6 months, you can see, when I put the biorazor now, she got lip incontinence. Because what? Because she was a mild high-angle case. It's different from those low-angle cases. So you have to be aware of the lip incontinence. When you see these things, you start aiding the biorazor. We have to remove it immediately. We don't have to. You keep an eye on that. So for me, 8 months, I stopped using the upper extrusion spring because I thought I cannot actually upper anymore because I don't want to rotate the manual more. But in nowadays, if I could do it again, I will keep using the extrusion spring to increase the upper inside the display, but reduce the height of the biorazor. That could be a better idea. Then removing the upper extrusion spring. So 14 months, I maintain the biorazor and intervention elastic and just watch, observe for the stability of the mandible and the occlusion. 14 months, you can see now the lip incumbents improve. Why does it improve? There's a molar intrusion, there's a relapse of the mandible up close. So just wait and see what happens. You don't have to get panic when you see lip incumbents. 21 months, I remove the biorazor. And again, when I remove the biorazor, keep using the intervention elastic for stability. So 27 months, that means I observe for another 6 months before I debone her. So now she has a class 1 occlusion from class 3 to class 1 occlusion. Look at the upper incisor angle and look at the lower incisor angle. There's no retrocline lower incisor. There's no procline of the upper incisor angle. And it's a class 1. Before and after treatment comparison. So you can see a little bit of that triangle in the lower. Why is that? I think I had a little bit of visualization of the lower dentition, and at the same time, I into the lower by a very short period of time. I did not really into the lower entity. So retraction and extrusion. So you have to be careful about the lower back triangle, especially when the synthesis is not too thick. Okay, the profile check, the improvement. I think she got a beautiful smile, upper incisor display beautiful. The chin projection is just good for class 1 patients. But especially when you look at her chin height, especially look at chin height, I feel like her chin height stays a little bit more for Asian female patient. Well, if I were able to reduce the chin height a little bit, I think her chin was better, profile even better, although the chin projection is excellent. But the chin height could be issue. So the CT scan after treatment, very good, but again, the chin height. So superimposed, you can see the mandible actually went backward for 4 to 5 millimeters, then repositioning, and the total facial height increase. Then where comes the total facial height increase? Because 4 to 5 millimeters of upper dentition extrusion, the lower you can see 5 to 6 millimeters lower anterior extrusion. There's no wonder her facial height increased so much, her chin height increased so much. And what I should have done is, I should into the lower incisor as good as possible. You see, for the first patient, the lower angle patient, I say, I shouldn't intrude because I want to increase the chin height. But this patient, because of high angle, I want to reduce the chin height, but I did not. So So before and after treatment, you can see upper intestine display better, increase facial height and chin height before and after. Is that true? That's in CT scan. So on the CT scan, as you can see, the distance from eye to upper to the lip line increase. Okay, and the total facial height increase. Is there any increase of chin height? That is to show the increase of the lip height, eye to lip height increase when you see that from the photos. And yeah, the eye to lip height increase could be big because actually our brain. So reason why, yeah, the actually our brain can increase the eye to lip height. The chin height increase, yes. You can see before and after. I put the lip line at the same level, and you can see the chin edge, the chin height edge shortened. So which is very interesting. Chin height increase you can see before and after. So don't think surgery is the only way that we can change the bone. There's another way we can change the bones. So increase of chin height could still make the patient look big chin or fluffy chin and the frontal profile. So do not overlook the chin height when we are treating frontal patients. So increase the chin height could be due to the low angle actually, especially in this case. Yeah, could be. So for an average angle to average to mild high angle patients, actually upper dentition and dentition might be good for, and also at the same time we have to avoid extrusion of the lower dentition and increase the chin height. So we have to avoid that, especially actually the lower dentition and increase of the chin height. So for these very high angle patients, she already had an excessive chin height before treatment. So I'm going to show you surgically how we're going to reduce it. Of course, when we think about we're going to reduce the chin height, the best way is you're going to reduce from the bottom. Okay, you're going to reduce the bottom. So you're going to have a genioplasty to cut it. So in this case, high angle, very high angle. Okay. But she didn't want to have surgery. So plus 1 malocclusion and lower than midline to the right side for 2 millimeter or because of chin deviation. So 4-5 extraction because she had high angle class 3 bilateral protrusion and have 4-5 extraction and MS retraction of the upper and lower dentition. 8 months apply of bi-razor because I would like to put the chin back a little more, but not too much. Cannot be too much because she's a high angle. And 11 months the special project completes and the dental line is on. But don't forget the bi-razor is there. Actually, the bi-razor can help to improve the dental line as well because you are repositioning the cornea position. 16 months, keep on the bi-razor, to keep it there, and the lower intrusive labor arm, and then observe for the stability. 20 months, remove the bi-razor and the lower intrusive labor arm. Again, keep using the intermetrial elastic and watch for the stability. So 21 months of integration in the good overjet in class 1 macroocclusion. Before and after treatment, I think yes, the plastic profile should improve, but the chin is still big, the chin height. So right next month after the deboning, so that is the superimposed before and after. You can see there 2 millimeter downward backward position of the mandible. So the chin height actually became longer, 1.5 millimeter extrusion after dentition. 2.5 millimeter extrusion of the lower dentition. There's no wonder that I increased the total facial height. So you can see before and after, you can see increase of chin height in this patient after treatment. I should have increased that. Eye to lip height also increased as well. If you can see this the lip line. So after treatment, in the months after treatment, she went for a vertical reduction genioplasty. Can we to reduce the chin height? That makes sense because you want to reduce the chin height that means that you reduce the front button because you really reduce the height. 15 months after surgery, okay, recently did relapse. And the CT scan showing after treatment and 15 months after the reduction genioplasty, we have around 5 to 6 millimeter reduce of the total facial height. And soft tissue chin also, the soft tissue facial height also reduced for 5 millimeter. And the main reducing is at the chin height. So the chin height, because of surgery, we have a vertical reduction in genioplasty, so that have reduced. Stability of occlusion remain very stable. Okay, they remain very stable. So that is before treatment, after treatment, and 15 months after treatment. That means 15 months after the surgery of the vertical reduction genioplasty. So you can see the chin height actually increased after treatment, and then after surgery, the chin height reduced. So the CT scan before treatment, after treatment, and after 15 months after surgery, you can see the change of the chin height. Yes, so that makes sense for me, like if you reduce the chin height from the bottom up, that makes sense. The question will be, are we able to reduce the chin height from the top down? If we reduce it from the top down, that means we are doing the low incisor intrusion to reduce the distance. But you're gonna question me, when we into the lower incisor, are we able to really reduce the soft tissue chin height? Well, for the bony tissue, yes, of course, absolutely. Like the absolute measurement, no matter you are reducing from the bottom or reducing from the top, I think the length will be different. But in terms of soft tissue, maybe that kind of stuff. So are we able to decrease the chin height without surgery? I will give you the answer of this patient, 24 years old, female patient, class 3. Okay, high angle. So class 1, class 3 endoprospite with endocardium, upper denominator up to the right with the chin deviation. Okay, and my plan first relieve endocardium, followed extraction relieve the endocardium and lower what's doing the MS anterior retraction with intrusive labor. So again, I had to do it because my plan was to reduce the chin height. The 30 months, because after 30 months of treatment, after special procedure, the lip incumbent still have a little bit lip incumbents. So what I should do is, I have to bring the upper and lower teeth back, special lower teeth back, and reduce the chin height. If I can reduce the chin height, that also help to improve the lip incumbents. So this is what I did. So I use lower trace to do furthermore of total digitalization, and also at the same time use the trace to do anterior intrusion. For the anterior intrusion, it's up to you. You want to put it trace in here, fine. So you can do it in your walkway. You don't have the final mind. I prefer to put the trace in the back and use the candidate arm to into the lower anterior. So 20 months of that, I start lower total digitalization because her lip now, the lip parts improve, but I maintain a low anterior intrusion and watch for the stability because you're gonna have to relapse. So I wanted to keep it there for a couple months before I remove the braces. The 24 months, I start lower intrusion and just watch for the stability. And 26 months, I finished it. Into a class 1 occlusion, good overbite over to a denominator on. To change color of her face. So let's look at the CT scan. This CT scan after the treatment. Let's look at the superimpose. You can see the mandible went backward 4 millimeter, 3 millimeter downward in position. There's a little bit of increase of total facial height because of 3 millimeter of downward reposition. So it comes from the upper anterior posterior have 3 millimeter of extrusion, which is good for the classification. So the lower, the distance from lower incisor to the menton, before and after, there's a 3.8 millimeter of extrusion. There's quite a good amount of the lower incisor intrusion. That means the chin height, the bony chin height decreased for 3.8 millimeter. Again, the superimpose on the mandible, you see a little bit of extrusion in the lower parts of the teeth, but mostly 3.8 millimeter intrusion of the lower end of the teeth. Does that intrusion goes to soft tissue? So let's see. Before treatment, before I apply the lower case for anterior intrusion, and after treatment, you can see in between, actually the chin height increased a little bit, and then after treatment, you can see the chin height decrease. Okay, then the chin height decrease. You can see from the superimpose, you can see, yes, the chin height decrease after that. And frontal view, you can see also the chin height decrease as well before and after. Superimpose to see the eye to lip height actually increase. So for a classic patient, you decrease the chin height, increase the middle face, then the face ratio for classic patients becoming better. So this is another example to decrease the chin height. This is another patient. This is my still working patient. 25 years old. She is an English teacher. So she really cares about where her upper and lower teeth is, because that could affect the pronunciation when she teaches English. So high angle again, this is quite a high angle platinum prognathidum with bimetal protrusion. So intraoral you see crafty and open bites, bimetal protrusion with intercrown. Okay, when you look at the canal relationship, especially on the right side, then you might be afraid like, no, I won't able to do it by tooth. If you're only thinking about occlusion. But when you're thinking about bone treatment, then that won't be the problem. So for this patient, upper 5, lower 4 extraction for the bimetric protrusion and also for the intercrown. And then I have a lower MS and anterior retraction. And at the same time, you can see there's an intrusive labor arm to intrude the lower anterior teeth before I put the screw. So 18 months, once I close the space, then I started to put tests in the lower. The tests also help to further visualize the lower dentition and also to do lower anterior intrusion by using tests. Okay, you can use molar to intrude, but what I'm seeing in my patient is it's much more effective than using molar by using tests. Tests can give you such much better intrusion at the lower anterior teeth. 26 months, lower anterior intrusion with tests keep going on. Then upper extruding labor arm for the upper anterior extrusion. Because now you can see I intrude the lower incisor. When I intrude lower incisor, you're going to have open bite again, right? So the policy will be you want to bring the upper teeth down. So the upper teeth has to be extrude. And that is good for classification because you have increased the upper incisor display in this patient. So 26 months, just a few months before I came over here, that is her change of her facial profile, progress changes. So before I into the lower incisor using tests, and recently 3 months after using the lower test for lower anterior intrusion. So I took a CT scan to see whether am I doing good currently for what I was planning. So you can see there were 3 millimeter of mandibular backward downward positioning. Yes, the total facial height decreased, but upper lower dentition being well retracted. And superimposed for the maxilla, there was 1.5 to 2 millimeter extrusion of the upper anterior and posterior teeth. And I have measurement for lower incisor to the menton. So totally I shortened for 2.7 millimeter of the bony chin height. Does that goes to the soft tissue? So that is very, very super important to see the lower intrusion and a little bit of lower molar intrusion, or even there's very little. Actually, the red color what you see is the other, is the opposite side, is the lingual side. So actually, the molar actually did not have intrusion. So this is frontal view for that, for the mandibular superposition. So, some teacher measurement for whether the lower chin height decrease, yes. You can see when we enter lower incisor, which also reflect to the soft tissue expression if the patient doesn't have lip incumbents. But if the patient has lip incumbents, that's another story. So you have to pay attention to lip incumbents as well. The eye to lip height actually increase slightly, not too much, because we actually are very confused. So all those cases show you what? When you actually are petite, that changes the length of the middle face, especially this part. The eye to lip height will be able to be controlled. The chin height also will be able to control. If I'm able to control this incarceration, are you able to use that incarceration into the opposite? Okay, that is possible. So again, bone driven instead of occlusion driven. What I'm using is brackets, wire, eraser. That's it. I'm not using too much fancy things, expander, marking. I'm not using that. I'm using braces and wire and barriers. Okay, overall super is showing you a little bit increase of eye lip height and the chin height actually decrease in this patient. So showing you the eye to lip height, chin height decrease. So to decrease chin height, that means the lip to lengthen distance, the height, could be possible without surgery by truthful women. So don't think that we are not able to do these things. Yes, we are able to do this. Only if you change your mind. You change your thinking process, the act that you're doing will be totally different. I use the same tool. You see, I'm using the same tool, but I'm acting differently than you are. Maybe I'm a weird guy. What? My patient was better. Your patient bites was better. My patient face was better. Also, occlusion was better too. So, take home message. Number one, use bone-driven concept instead of occlusion-driven concept into the transfer patient. Number two, contour chin projection and chin height are both important in treating traumatic patients. Use razor and intermediate elastic to decrease the chin projection. Okay. Use tape to extrapolate entities and increase eye lip height. Use tape to ensure low entities and decrease the chin height. Take-home measure number two. Apply classic razor and intermediate vertical elastic for immediate classic facial profile improvement as early as possible in low-angle patients. Okay? In low-angle patients, apply razor as early as possible. Do not ensure low entities in low-angle patients. It's opposite to high-angle. Can actual upper low as good as possible. Don't have to ensure low entities in low-angle. Number three, be aware of the chin height, lip incumbents, and do not apply razor in the early stage treatment in high-angle patients. So you don't want to put razor right at the beginning for the high-angle patient. So use tape for low-angle intrusion in average to high-low-angle patients. To average to high-angle patients. Thank you very much, and I hope that can help you to practice with your partner.